All right, so let's finish chapter 18, talking about female reproduction. We'll do it similar to what we did with male reproduction. Just kind of go through the tract. Basically, the gonads here are ovaries instead of the testes, where oocytes, as opposed to sperm, mature into ova. The female reproductive tract includes uterine tubes. Think uterine tubes are similar to the vas deferens. The uterus is a site of embryonic and fetal development, and the vagina is the site of sperm deposition, which is also called the birth canal, but it's a passageway for menstrual fluids as well. So if fertilization doesn't occur and baby is not created, then a menstrual period happens roughly once a month, but it varies. So we'll talk a little bit about that. The female reproductive system is a little bit more complicated than males, so we'll spend a little bit more time on it than we did males. But we'll plug along and get through then again as well the external genitalia. So we'll run it similarly to how we did males. And there's obviously a couple of accessory glands like mammary glands. There's another set of glands in and around the vaginal canal that help with lubrication. So we'll talk about those a little bit as well. But there's not as many accessory glands as there are in males. There's just a slightly different mechanism that's happening with regard to the endocrine system, because there's a second hormone as opposed to just testosterone in males. There's estrogen and progesterone in females, and that the amount of estrogen and or progesterone that is secreted changes depending on the part of the menstrual cycle that we're in. There's actually 2 phases of the menstrual cycle. And then we'll throw the uterine cycle in there as well, which kind of complicates things. So there's 2 ovaries. They have 3 major functions, similar to the male testis. It's production of oocytes, but also secretion of female sex hormones, estrogen and progesterone. And just like in males, inhibin is also secreted, which inhibits FSH, follicle stimulating hormone, from being produced from the pituitary gland. So a similar feedback mechanism in males that there is in females. The uterine tube or fallopian tube is basically a funnel that opens to the pelvic cavity, which is opens up into the uterus, that when an oocyte is ovulated, expelled from the ovary, it travels along the uterine tube all the way to the uterus, where if fertilization occurs, it actually happens in this uterine tube. And then basically sends the fertilized oocyte with the sperm that fertilizes the oocyte to the uterus to mature and grow into baby. It is inferior to the ovary, and it's usually angled forward above the urinary bladder. So I'll kind of show you where that's located. It's on one of the figures previously. And then from the uterus connects directly to the vagina, which is basically also called the birth canal, which extends from the uterus to the external genitalia. And there's a few accessory glands. Again, I mentioned those accessory glands that are around the vaginal entrance. They're there mostly for lubrication of that vaginal canal and the external genitalia during intercourse. And those external genitalia are the clitoris and labia. So we'll talk about those along the way. Let's look at these here. So right here's your uterus, the uterus, not necessarily your uterus. The ovary here, where oocytes mature and then are ovulated or expelled into the uterine tube. So the fallopian tube is here. The fallopian tube connects to the uterus, and this uterine cavity here is where the fertilized oocyte is sent, or not fertilized for that matter. If it's fertilized, it stays there and eventually implants into the wall of the uterus and becomes baby. And if it is not fertilized, then it gets expelled during a menstrual period. Then right here at the very kind of distal and inferior end of the uterus is the cervix. The cervix is what opens up to the vaginal canal. Here's the vagina, and then the external genitalia are here, right? These little blue dots here are the accessory glands that help secrete fluid that lubricates the vaginal canal, and the external genitalia here, which where the clitoris is located, and then the labia, the clitoris is here, excuse me, and then the labia, minora and majora. So those are the external genitalia in females. So there's a couple of ligaments that hold the reproductive organs in females kind of in place in the cavity in which they reside. So think about the pelvic cavity and the abdominal pelvic cavity where all of these organs reside, organs and structures reside. There's an ovarian ligament. It extends from the uterus to the medial surface of the ovary. So it kind of connects the ovary, holds the ovary to the uterus. I'll show you this on the next slide. If you want to pop forward to that slide, you can stay here while I describe it, but I'm going to stay on this slide while I do so. The mesovarium is part of a larger ligament called the broad ligament, which extends basically across the surface of most of the reproductive organs here. It's a fold of mesentery, and mesentery are basically membranes that surround abdominal pelvic organs. So the mesovarium is the part of this big ligament called the broad ligament that surrounds the ovary itself and holds the ovary to the fallopian tube. The suspensory ligament suspends the ovary to the lateral surface of the pelvic wall. So if the ovarian ligament is medial, the suspensory ligament is lateral and holds that ovary, kind of suspends the ovary in place laterally to the wall. And then the broad ligament, again, I mentioned earlier, the mesovarium is part of the broad ligament. It's pretty extensive and it surrounds most of the uterus. It's pretty extensive with regard to its size, but it surrounds and extends, basically attaches to the sides and the floor of the pelvic cavity and holds the uterus and ovary and fallopian tubes in place and helps protect them as well. So take a look at this guy. Again, this is the ovarian ligament. It's actually labeled here. It's medial on the ovary and holds the ovary to the uterus. The suspensory ligament is here laterally on the ovary and suspends the ovary to the lateral wall of the pelvic cavity. And then the broad ligament is this huge broad ligament, a section of which is called the mesovarium. It's pointed out here, but actually surrounds the ovary completely and again holds the ovary to the fallopian tube, kind of keeps them closely associated, which is really important because the ovary is releasing an oocyte or an egg and sends it right into the fallopian tube. So if these detach one another, there's no real physical connection other than this ligament to those two structures. So they need to be closely associated with one another, and that ligament helps do that. And this broad ligament, again, basically resides over top of all of the reproductive organs in the female reproductive tract. So oogenesis, like spermatogenesis we talked about in males, oogenesis, mitosis occurs to produce oogonium, which basically produces two daughter cells that are identical. And one oogonium is one of that division, and the primary oocyte is what continues into meiosis 1. Meiosis 1 occurs in females between the 3rd and 7th month of fetal development, where primary oocytes are basically prepared for meiosis, but the process is halted. It's actually stopped in prophase 1. So remember, there's two major steps in meiosis, meiosis 1 and meiosis 2. And in meiosis 1, there's prophase, metaphase, anaphase, and telophase 1. So the four steps of mitosis occur in meiosis 1, and they're just prophase 1, metaphase 1, anaphase 1, and telophase 1, where you get splitting of those two cells into daughter cells. But in prophase 1, these cells get halted until puberty, when follicle stimulating hormone from the pituitary gland rises. It's an indication that puberty is happening, basically, hormonally. Obviously, we don't see that externally. You have to actually measure it in the blood. So at puberty, FSH levels rise, and that triggers the primary oocytes to continue with meiosis 1. So meiosis 1 continues. The primary oocyte divides into one secondary oocyte and something called the first polar body, which doesn't continue in it's kind of structure that doesn't do much from this point forward. And each of them has 23 chromosomes. So these are haploid cells at the end of meiosis 1, like a typical meiotic division. The secondary oocyte gets the majority of the cytoplasm and then enters into meiosis 2. So the secondary oocyte begins meiosis 2 The first polar body may or may not complete meiosis II. So it kind of just can be halted there for a period of time, and doesn't necessarily enter into meiosis II. Then in meiosis II, the secondary oocyte gets suspended. It stops its process in metaphase II. So where like the chromosomes line up on the metaphase plate, in metaphase II, the chromosomes line up so that the sister chromatids can divide, but they don't divide. So you don't continue into anaphase II. You stop here. If fertilization doesn't occur, the oocyte, secondary oocyte, divides into a second polar body and an ovum that are both haploid. And the ovum is what unites with sperm. And the polar bodies just degenerate if fertilization does occur. If it doesn't occur, meiosis II is just not completed. So the presence of the sperm and fertilization itself is what is the signal for the oocyte, secondary oocyte, frozen in metaphase II to continue the meiotic division and create a second polar body with the second division, and then the ovum, which is what will develop into the diploid eventually with the sperm's haploid chromosomes and the ovum haploid chromosomes. They will combine together, unite, and become a diploid cell, and the polar bodies just degenerate. So there's a figure of the process. So if you want to go back and listen to what I just kind of walked through with this actual figure, if you were doing that already, that's great. So mitosis of the oogonium basically provides an oogonium and then a primary oocyte that will head into meiosis. This will continue to divide, head into meiosis, and then be frozen for a period of time until puberty occurs, which then stimulates meiosis I to continue. That'll get frozen in prophase I. And then meiosis I is stimulated at puberty, again, with the production and increase in production of FSH, follicle stimulating hormone, one of the two gonadotropins. Those luteinizing hormone is the other one. But FSH is one of the major indicators that puberty is occurring. And it increases in the circulation quite a bit. So the first polar body is created during meiosis I. The secondary oocytes produced. First polar body can then undergo meiosis II as well later only if fertilization occurs, because this secondary oocyte remains frozen in metaphase II. And then if metaphase II then basically if fertilization occurs, metaphase II continues, and the second polar body is produced in that second division, the second meiotic division, and the mature ovum is what is fertilized and will eventually grow with sperm into fetus. So that's how oocytes mature. The ovarian cycle involves changes in ovarian follicles. So within an ovary, a follicle is where an oocyte is encased. It's held inside a follicle to grow and mature and be protected until ovulation occurs. And ovulation is basically just the expelling of an oocyte from the mature ovarian follicle into the fallopian tube or the uterine tube. You have basically at birth close to 2 million what's called primordial follicles. And primordial follicles contain a primary oocyte. So remember, the primary oocyte is what is arrested in prophase I, right? Back here. So excuse me, it's not the primary oocyte. It's the secondary oocyte. I said that wrong. So the secondary oocyte is what's held in this primordial follicle. Well, they have a primary oocyte in the primordial follicle. By puberty, there's 400,000 primordial follicles. Each one of them contains a primary oocyte. The others have degenerated in the process called atresia. So if something becomes atretic, it's just dying off. Each month, follicle stimulating hormone, FSH, stimulates the development of several follicles, not just one, several. And basically, here's what happens. These follicular stages. Formation of the primary follicle occurs from the primordial follicle. So basically, follicles just enlarge, they divide and form several layers of cells around the primary oocyte. And that several layers of cells, there's a clear region around the oocyte. It's a layer of tissue called the zona pellucida. And follicular cells around that zona pellucida, those several layers of cells are called follicular cells. They start to produce estrogen, one of the two primary hormones. They then develop into secondary follicles. As the primary follicles enlarge and divide, they mature into secondary follicles, which have an even thicker wall of follicular cells that secrete fluid. And that fluid creates a pocket. That secretion of fluid creates a pocket that separates the inner layer and outer layer of follicular cells. That development from secondary, creating this fluid-filled pocket, develops a secondary follicle into a tertiary follicle, or a mature Graafian follicle that forms by day 10 to 14 of one menstrual cycle. Around that follicle, around the oocyte is a layer called the zona pellucida, surrounded by a layer of follicular cells. The follicular cells that surround the zona pellucida that's encasing the oocyte is called the corona radiata. It's the protective layer of cells around what's now the secondary oocyte. And that basically, the chamber in which that fluid is secreted expands to the chamber. It's called the antrum, that is filled with follicular fluid. And at the end of the follicular phase, there's what's called basically is ovulation. So ovulation is the release of the oocyte from the follicle into the fallopian tube. And ovulation basically separates the two phases of the menstrual cycle or the ovarian cycle. They're called the follicular phase, when follicles are developing and growing and maturing, into one major Graafian follicle. And then once ovulation occurs, the luteal phase begins, where something called the corpus luteum, a structure called the corpus luteum, develops. And the corpus luteum is a structure that is basically a collapsed tertiary follicle. So when the follicle ovulates and releases an oocyte, it changes the cell makeup, basically how the cells function, and becomes the corpus luteum. So the corpus luteum is the tertiary follicle the corpus luteum becomes the corpus luteum once the tertiary follicle releases the oocyte. It kind of changes the intracellular makeup of the cells of the follicle, start to change a little bit. They respond to the hormones like luteinizing hormone, and actually start to produce more progesterone than estrogen. And progesterone being secreted from this corpus luteum is what stimulates the maturation of the uterine lining so that it can support implantation of a fertilized egg and produce baby. If fertilization doesn't occur, then by about day 12 to 14, progesterone and estrogen start to plummet because the corpus luteum degenerates. So if fertilization doesn't occur and there is no sperm fertilizing the oocyte, then obviously there's no signal from that. There's a complex that forms to start to produce baby. And that complex, if it doesn't form because fertilization doesn't form, then there's no signal being sent to the corpus luteum to stay healthy. And if the corpus luteum doesn't stay healthy, it will stop producing as much estrogen and progesterone, and the uterine lining won't be maintained. And that marks the end of the ovarian cycle, in that those hormone levels go down and the corpus luteum degenerates. And basically that initiates a menstrual period. So here's primordial follicles that develop into primary follicles, cell layers, and right there, that thick purple line is the corona radiata, or the zona pellucida, excuse me. The cells continue to develop and start to secrete fluid, and then eventually the antrum develops with the fluid here. This is the corona radiata around the oocyte that's developing. The zona pellucida is right there, and more follicular cells around. This is when ovulation occurs. The corona radiata and zona pellucida go with the oocyte during the release of the oocyte, ovulation, and this tertiary follicle that has ovulated becomes the corpus luteum. And if fertilization doesn't occur in this oocyte, then this corpus luteum degenerates to the corpus albicans. So let's talk about the uterine tubes. They're hollow muscular structures, not very long, but they have three sections, the infundibulum, that have finger-like projections on them called fimbriae. I think it looks like a baseball glove. Basically, those are close to, but not touching the ovary. Remember, there's no physical connection between the ovary and the fallopian tubes, other than the membranes, the ligaments that surround them and keep them together, keep them close by. And cilia line the infundibulum that basically beat towards the uterine tube. So they basically take the oocyte and just kind of wave it towards the uterus. And then the ampulla is the middle segment, and the isthmus is a narrow portion that's connected to the uterine wall. So here's the fallopian tube. There's the fingers, the fimbriae. An oocyte, when it's ovulated, gets basically shot into the fallopian tube through the fimbriae that are kind of collecting that, and then into the infundibulum, which is just this neck behind the fimbriae. The ampulla is the longer section, and then the isthmus is where it narrows into the uterine cavity. The uterus has three major layers. The innermost layer is called the endometrium. Think innermost lining, endometrium. Metrium is uterus. The myometrium, myo is muscle. So the myometrium is the thick middle muscle layer of the uterus. And then the perimetrium is the outer surface, which is basically continuous with like the broad ligament, which is part of the peritoneal lining. So those mesenteries, the broad ligament is part of that. So that broad ligament makes up most of the perimetrium. And there's two parts, the uterine cavity, which is the larger superior chamber, and the cervix, or the cervical canal, which is a constricted passageway. So if you've ever had a baby, or if you know somebody who's had a baby, and the doctor is looking for cervix dilation, there's an indication of dilation. So the cervix has to dilate, increase in its size of its passageway before baby arrives. And that basically dilation of the cervix is what's preparing for and allowing for baby to be able to move through that canal, through the vagina, actually. So there's the three layers: endometrium, myometrium, super thick, and the perimetrium, this outer layer. And there's the two cavities, the uterine cavity and the cervical canal. So this whole section here is the cervix. This is the cervical canal. These three major regions, again, fundus, body, and cervix, we've talked about, that projects into the vagina. The body's the largest portion. And then the fundus is the upper rounded portion. And that's usually where the uterine tubes attach. So right here is this upper rounded portion. This is the fundus. This is body. And then the cervix is just this lower portion that's kind of narrowed through and enters into the vagina. So if fertilization occurs, basically the secondary oocyte is penetrated by a sperm. Remember, on the sperm, in the head of the sperm, there's a structure called the acrosome. And the acrosome is secreting enzymes that penetrate, that are able to kind of break down the wall of the layers of cells and tissue that are surrounding the oocyte, like the corona radiata and the zona pellucida. Those two structures need to be kind of broken through, and the acrosome is what helps the sperm do that. In the uterine tube, the fallopian tube, is where fertilization occurs. And in the secondary oocyte, once it's ovulated, you only have about 12 to 24 hours after release for fertilization to occur. So think about that. You have a day or less, a window of time that is so short for fertilization to occur. It's so magical. But basically it starts to degenerate after that time. So if fertilization doesn't occur, the oocyte just kind of goes, yeah, I don't need to be here anymore. There's no sperm to fertilize me. I don't need to become a baby, so I'm just not. It takes 3 to 4 days for the secondary oocyte to actually reach the uterine cavity. So its travel time is relatively long from fertilization to the point where it enters the uterine cavity. If that doesn't occur, again, a menstrual period happens basically and gets rid of all the machinery that the uterus once had that would allow for implantation of baby and growth. The vagina is extremely elastic. There's a lot of elastic fibers to allow for expansion. It's very distensible, but it has a muscle as well. There's muscle in the wall. It extends to the vestibule, this area here where the vestibular glands, the accessory glands here that surround the vaginal canal, secrete fluid to lubricate the vaginal canal during intercourse, which is basically your passageway to and from the uterus. In the external genitalia, in the vestibule, you've got, and what creates the boundaries of the vestibule are the labia minora. In that area, there are two glands, lesser vestibular glands that basically moisten and allow lubrication of the vestibule, and the greater vestibular glands that are only activated during sexual arousal. They're similar to the bulbourethral glands in males. So they're providing a kind of mucousy fluid that helps lubricate the vaginal canal and also the vestibule. The external genitalia, the mons pubis, is a bulge of adipose tissue deep to the skin and superficial to the pubic symphysis, where your pubic bones come together. And then the clitoris is basically what projects into the vestibule, and it contains erectile tissue that's comparable to that erectile tissue in the penis. And the prepuce is formed by extensions of the labia minora that encircle basically the clitoris. And the labia majora are larger folds of skin that encircle the labia minora and all the adjacent structures. So here's the prepuce. The clitoris is encased in that. This is the opening to the urethra and opening to the vaginal canal. The labia minora are here, and the labia majora are here, and then the mons pubis is where hair basically grows there. So that's external genitalia. For the female, the mammary gland is one of the major accessory glands, and it's really important in the growth and development of baby, right? So it basically is responsible for milk production or lactation that's controlled by hormones. A hormone called prolactin is really important in the production of milk from the glands and the breast tissue. Each mammary gland is divided into lobes, and those lobes, each lobule, they're separated into lobules that have what's called secretory alveoli. The ducts from the lobules basically converge into one lactiferous duct per lobe, and then expand near the nipple to form lactiferous sinuses. The nipple is basically that conical projection that's surrounded by reddish brown skin, which is the areola. It has typically a grainy surface because there's a lot of sebaceous glands that are deep to that. So if we follow it, this is all one mammary gland. The mammary glands are separated into lobules, and those lobules are into lobes, This is one lobe. These tiny, smaller lobes are lobules, right? This is one lobule that empties into, all the lobules empty into one lactiferous duct. That duct empties into a sinus, and those sinuses converge together collectively to excrete milk from the nipple itself that is surrounded by the areola. That is one structure of a mammary gland. There's a lot of suspensory ligaments in there that kind of help keep everything in place, and a lot of adipose tissue as well. So the hormones and cycles, this is what makes females a little bit more complicated than males, because we talked about the endocrine cycle in males, but the females, there's two different cycles. There's an ovarian cycle, a menstrual cycle, but also a uterine cycle. And the ovarian cycle and uterine cycle are controlled by cyclical changes in hormones. And the two cycles are basically in sync, and they have to be for proper reproductive function. So monthly hormonal fluctuations basically cause physiological changes that affect body temperature and a number of things. During the luteal phase, so there's two phases. The first phase is typically the follicular phase, not typically, where high estrogen is produced, high amounts of estrogen. That causes an increase in basal body temperature that drops during the luteal phase because there's high progesterone production. There's two different hormones. The menstrual cycle begins at puberty, and the first cycle is called menarche, typically around the age of 11 to 12, but that can go up to 13, 14, 15, and can be as young as even 8, 9, 10 years old. I have heard of some individuals having their first menstrual cycle at 9 and 10 years old, which is really young. Averages are about 28 days for one menstrual cycle, but there can be a range that is considered normal from 21 to 35 days. And that range can vary quite greatly from person to person, but also within the same person from month to month. So not every woman, and very few women I know, have a menstrual cycle that is the exact same number of days every month. It tends to vary quite a bit, especially when you're younger. And that will continue until menopause, which is about the age of 45 to 55. And that also varies from woman to woman. Menstrual, and I keep saying that I mentioned that the menstrual cycle can vary in the same woman from month to month, and it can actually be interrupted or affected by illness, stress, starvation, or pregnancy. And starvation is a unique instance, because in starvation, your body starts to go into starvation mode, and it basically starts to shut down temporarily some systems that you don't need to stay alive and keep yourself alive. And one of those systems is your reproductive system. You don't have to reproduce to keep yourself alive. So in that instance, the hormone cycles will get shut down and basically shut down the reproductive system and its functions for a period of time until you're out of starvation. Your body is really, really, really smart. So I think it's pretty cool that can happen. It's scary because you just start to lose your menstrual cycle and you don't get a menstrual period. You might not get a menstrual period for a period of time, but stress can do the same thing. When your body is stressed out, it doesn't want to reproduce. And in that instance, stress hormones can have a huge impact on menstrual function, and normal menstrual function can kind of throw things way out of whack. So here's the hormones. Check this out. This is the follicular phase, separated by ovulation. Mentioned that once before. And the luteal phase, where the corpus luteum develops, right? So during the follicular phase, follicles are developing to a tertiary follicle that ovulates. And then that ovulated tertiary follicle becomes the corpus luteum, and without fertilization becomes atretic and dies off, basically. It degenerates. The first half of the cycle, estrogen is the predominant hormone in red, and then in the luteal phase, progesterone becomes the dominant hormone. So the follicle in the follicular phase is producing estrogen predominantly, a little bit of progesterone, and then the corpus luteum in the luteal phase is producing predominantly progesterone, but still some estrogen, right? And of course, there's inhibin as well that inhibits FSH production. The endometrial lining, which is what builds up during the follicular phase. So this is the uterine cycle. There's basically menses and proliferative phase, where the menses is basically the removal of this endometrial lining. The proliferative phase is it builds back up. And then during the secretory phase, it's been built up and is able to support implantation of a fertilized egg if that has happened. But if it doesn't, this starts all over again. You get rid of the endometrial lining, build it back up. It's sufficiently built here and can support implantation of the fertilized egg. If that doesn't happen, starts all over again. If this does happen and implantation does occur, then this endometrial lining will be maintained and supported throughout pregnancy, because it sends a signal to the corpus luteum to stay mature and healthy, and it will continue to produce progesterone, which then comes back to the uterus to say, you need to stay healthy, and it'll allow that to happen. This cycle of hormone release back and forth between the corpus luteum and the endometrium happens all throughout pregnancy to keep both structures, the endometrium and the corpus luteum, completely healthy. In cancer, in males, we talked about prostate and testicular cancer. Breast cancer is the leading cause of death in women ages 35 to 45. Scary, right? Which is why at the age of 35, you're supposed to have your first mammogram, which is your only screening process, your only screening technique to screen for and detect breast cancer. It's most common in women over age 50, but risk factors include family history, having a baby for the first time after the age of 30. There's a number of reasons for that. Getting your period for the first time early, so early menarche, again, like ages 8, 9, 10, as opposed to 11, 12, 13, 14. And late menopause is also a risk factor. It just has to do with some changes in breast tissue that can occur over time. And pregnancy before 30 can be helpful in preventing that. But a family history is one of the biggest impacts on that. Basically, treatment is mostly surgical to remove possibly the tumor itself, or even all of the breast tissue, depending. And if that's the case, a lot of times there's also a combination of radiation and chemotherapy, as well as potentially some hormones. But the removal of a tumor may only remove part or all of the mammary gland. It just depends. And potentially also the axillary lymph nodes, which are in your armpit. And those lymph nodes, again, if cancer spreads to lymph nodes, tends to make it much more severe, and it'll spread to other tissues. So to prevent that, you usually remove the lymph nodes that are nearby, which is over in your armpit area. Ovarian cancer is also really severe. It's the third most common reproductive cancer in women, but it's also the most dangerous. It's difficult to diagnose early. So that, again, screening and getting a normal pap smear at your gynecologist is really, really important. It basically originates from ovarian tissue with abnormal oocytes, similar to testicular cancer in men. 85% of ovarian cancers that are carcinomas are really treatable, and sustained remission happens in at least a third of all cases. So that's an example of ovarian cancer versus a normal ovary. Cervical cancer is the most common cancer in the reproductive system in women ages 15 to 34. A lot of cervical cancer comes from the human papillomavirus. It's responsible for 3/4 of all cervical cancer cases. There's a vaccine that is recommended around age 11 or 12, but if you already have HPV or have been diagnosed with it, the vaccination won't do anything for you. Your body can clear it over time. It's rare that happens, but it's possible. There's no treatment for it. So you have to be really careful and be screened annually in that instance to make sure that any cancer doesn't develop. It is pretty aggressive. Once it develops, it's pretty aggressive and it's hard to treat. So it can be pretty deadly. So let's talk about gross stuff. Sexually transmitted diseases. They're transferred in basically by way of sexual intercourse. There's at least 24 bacterial, viral, or fungal infections. Chlamydia is an example of a bacterial infection. AIDS, autoimmune deficiency syndrome, is basically a deadly. It's a viral disease caused by HIV. There are 15 to 24 million new cases of STDs in the United States each year, and half of those cases are in ages 19 to 24. I think the last time I looked at a statistic, 50 to 75% of women have been diagnosed with the HPV virus, or at least one STD. So it is extremely prevalent. You have to protect yourself, and we'll talk about how here, especially with regard to birth control. There's male condoms, obviously, and male condoms can help protect against STDs. So always use one. A diaphragm in females with spermicide can help, but does not protect you against STDs. It just protects you against pregnancy. So be careful with that. So there is latex, basically latex rubber with a small little metal loop that supports with a supporting rim, and it's fitted for you. So it fits around your cervix, basically, to cover that and prevent insertion or the movement of any sperm through the cervix and up into the vagina, where eventually in the fallopian tube fertilization would occur. So it just prevents pregnancy. It does not prevent STDs. Same thing with oral contraceptives. Any intrauterine device as well will not prevent STDs. But typically oral contraceptives are mostly a combined form of estrogen and progesterone, but when used properly are really effective in preventing pregnancy. There's also progesterone-only forms of birth control. But there's some risks that come along with that. Can worsen problems like weight gain, acne, hypertension, which is high blood pressure, You have an increased risk of blood clots, strokes. I mean, there's some really severe consequences of taking oral contraceptives that do not happen in everyone. You just are at an increased risk, or it can worsen the problems of diseases that you already have. So be careful with that. There are intrauterine devices, IUDs, that are inserted into the uterine cavity and can stimulate production of chemicals that basically create a harsh environment for sperm to survive and prevent that from happening. And these can be effective for up to a decade. There's an IUD that is a copper IUD. It's called Paragard. That's a copper IUD, and the copper just basically creates a harsh environment for sperm to survive. And you can be inserted and stay there for 10 years to where it needs to be removed. So it's pretty effective and an easy way to not have to forget to take a birth control pill. There's also preventative hormonal postcoital, and that's after intercourse contraceptives. These aren't recommended to take constantly or regularly. This is just like in an oops situation where you're concerned about pregnancy and haven't been on any form of oral contraceptive or intrauterine device and didn't maybe use protection. It reduces expected pregnancy rate up to 89%, but it has to be taken in 2 large doses in 12 hours apart within 72 hours of unprotected sex. So it is over the counter for women of 18 years of age or older. But again, it's not recommended to do that. Try to be protective in advance. Surgical sterilization is an option as well for individuals who choose to not have a baby or have had children and just no longer want any more. The vasectomy for males and tubal ligation for females. Basically, the vasectomy is the vas deferens are cut and blocked, so sperm production still occurs, but it has no transport mechanism to get ejaculated. There's a really small failure rate. But there's no disruption in sexual function. And vas deferens are similar, or ductus deferens are similar to the uterine tubes or fallopian tubes. So you basically do the same thing. It's just there's much more complication. Complications are much more likely than with a vasectomy because the surgery is just much more severe in women than it is men. The ductus deferens can pretty easily be located and surgery can be performed pretty easily. It's in the physician's office in minutes. Women actually have to undergo quite an invasive surgery to have a tubal ligation. So it's much more severe in females than in males. But both are options. So that finishes chapter 18. We are all done. There is an exam to take. Good luck with that. And I wish you the best of luck to finish up the semester.